therapeutic hypothermia. How many people think hypothermia definitely works after cardiac arrest and leads to good outcomes? I'm about 1/3 up. How many people, if their mother had a cardiac arrest tomorrow, would want hypothermia added to regular therapy? All right, so I think you're a reasonable group in things that we're talking. We're going to talk about some hypothermia cases. I got Gina here, so I can pick on ER doctors. That's good.
Hey, Jackie.
Another one? Jackie, you keep changing your hair color and style on me here since I tell you last. So we're going to talk about cardiac arrest. We're going to talk about some of the old and the new studies for hypothermia. I want to talk about our record of with the hypothermia protocol. And then I want to talk about triage, frankly, because I think that's a hot item between the two divisions and things and everything here about some other controversies and things that we're dealing with in terms of hypothermia. Again, cardiac arrest is hard. Cardiac arrest is a lot of different issues of ethics, emotion, medical resources, utility. There's very few conditions that have as poor a chance of surviving a hospital stay as cardiac arrest. And again, I think we alter as ICU and as doctors about, do we want to do these drastic kind of measures and things, but in other circumstances when, frankly, things we can probably predict are not going to go very, very well, do we have a responsibility in terms of stewardship and resources and putting burdens on our nurses and things like that? So again, I don't have all the answers for these things. I learn something every time I take care of these patients and things here, but it is a very, very difficult job for us physicians and everything here. Here's a typical couple cases. These are cases from this May, 53-year-old Filipino male. Not related to me, Rodeo. You?
Yeah, me too.
Maybe not related to you? Okay. I have a Filipino wife, so I've been to several Filipino weddings. That is a good place to have a cardiac arrest. There are lots of Filipino nurses and doctors in the area, seriously. So if you're going down, go down to the Filipino wedding. But this patient had bystander CPR, got defibrillated by the Windsor paramedics, EMTs. He was transferred to Windsor Regional, but got there like 12 a.m., 12:30 a.m. Pretty unremarkable EKG, maybe a 0.5 millimeter of ST elevation in lead V1. Sorry about the bad copy. But again, he was transferred directly to the cath lab, and like most patients with a VF or a VT, he ends up with severe coronary disease, so you see a 95% circumflex stenosis there. And you see, even though no ST elevation, he's got 100% LAD occlusion going on there. Which one's causing the problem? I don't know. Which one, everything. Dr. Koenig did some strong work on him here, so he was able to open up that LAD with an angioplasty and a wire. And again, you see a good result here is restored flow in the LAD. Patient was treated then with intravascular cooling and rewarming. He had no neurologic deficits despite that 5-10 minute downtime resuscitation. Had a troponin over 100 and a pretty big infarct with an EF of 40, but left, frankly, as a satisfied Henry Ford customer. Here's a case within a week of that one here, kind of the paradoxical side of cardiac arrest. So here's a 60-year-old with hypertension, schizophrenia, hepatitis C, alcohol, cocaine abuse. He came in with our own ED at a 4 o'clock or 3 o'clock on a Friday afternoon with weakness, shortness of breath, and mental status. He was hypothermic at baseline with tachycardia, tachypnea, borderline low blood pressure, sinus tachycardia, no changes in his EKG, but some conduction abnormalities. He had acute renal failure with a very profound metabolic acidosis and things at baseline. But again, he's semi-conscious and talking to the providers and things while labs are being. Anybody remember this case? From May and everything here? So while he's waiting there in the ER again, while the labs and everything, he has a PEA asystolic arrest. Like in all cases in the Henry Ford ED, they get him back. They get him back. 15 minutes, epi, 2 pressors, multiple bicarb boluses. His post-resuscitation gas is 6.62, PCO2 of 59, very easy to oxygenate. My fine ER staff colleague applies a cooling blanket to him and calls cardiology to consider the therapeutic hypothermia protocol. Okay. My fellow and I, we decided that this is metabolic acidosis, hyperkalemia, not an acute MI. We got an echo that showed his EF and everything. And again, we recommended no catheterization or hypothermia. We recommended that he definitely go to the more expert ICU doctors in the medical intensive care unit there and everything. He ends up with this note that irritates the heck out of us here. So the resident writes, cardiology evaluated the patient ED and recommended that the cooling protocol be stopped. Obviously, he was never on a cooling protocol. We don't recommend external cooling or cooling blankets or anything in the ER. If we're going to cool, we want to cool with official cool. He ends up with methanol poisoning, interestingly enough, and everything here. I don't know if that's lacquer or some type of additive or whatever thing here, but he was treated with the fomepizole and the hemodialysis. He never woke up, and he's a rare cardiac arrest. He actually met brain death criteria at 48 to 72 hours, and frankly, we were comfortable withdrawing care then, and he died in pod 3 or pod 4. I forget which one he was in there and everything here. So again, big difference in the two arrests and things here. This one, nobody feels good because he actually walked in with some stable vitals and things here. But he's a patient, again, who, as we talk about this therapy and triage, he's someone, again, we wouldn't recommend being real aggressive with in terms of cardiac procedures or cooling. So overall, cardiac arrest is going to deal with about 300 to 400,000 patients a year in the U.S. You're more often to die of this in coronary artery disease than you are from sequelae of myocardial infarction. So more people die outside of the hospital now with cardiac disease than in. And it's about 15% of all deaths. If you go down in the community with cardiac arrest, your overall survival across the industrialized world is somewhere in the neighborhood of 10 to 15%. Okay, so, and it is starting to get a little bit better. If paramedics and or ER doctors are able to get you back, okay, then you've got about a 40% chance, frankly, of walking out of the hospital. The majority of people that die of cardiac arrest do not die of multi-organ failure or sequelae or the post-cardiac. They die because, frankly, that initial period of hypoperfusion and everything, frankly, damages the brain permanently, and we as providers and families and patients usually withdraw in those cases due to the initial noxic brain injury, which is what does them in there and everything here. You clearly do better if you're earlier in the course of your cardiac arrest, when you're more likely to have VT and VF before you degenerate into idioventricular rhythms and asystole. You certainly do better if you're in a casino or an airport, somewhere where you're witnessed or around other people. You certainly do better with early defib. Pretty good data now, Japan and Europe, some major national registries that the message to non-medical people to forget about mouth-to-mouth and airway and just do compressions is starting to actually show some increased survival in some population studies. And again, amiodarone may get you a slightly higher percentage with return of spontaneous circulation, but again, not dramatic in terms of most of the studies and things here. What are you dealing with as a cause in most of these cases? This again compares the men and the women. And again, what you see is about 80% men are due to coronary artery disease versus 50% or so here. You see the heart failure, the valvular heart disease patients, and everything here. But you're left with only about 10%, frankly, are these normal structural hearts without ischemia, usually a combination of Brugada, long QT, pro-arrhythmic drugs, those type of things and everything here. But again, this importance of CAD is becoming more and more important because, again, we're considering cathing a lot more of these patients without ST elevation. So there's a couple of good studies that have looked at how good is the EKG at determining the cause of the cardiac arrest. So here's 212 patients who underwent cath in Slovenia, 2013 or so here. If you divide the patients up into those who had definite STEMI versus non-STEMI, what you see is that about 60% of patients, even without STEMI, have significant coronary artery stenosis. And again, about 31% or so without ST elevation either have an acute occlusion or an acute vessel that they thought was actually causing an acute coronary syndrome to do it. Okay? Versus 90-95% if you've got ST elevation, you've got a STEMI going on along with your cardiac arrest. Here's an Italian study, again, about 126 patients, same message. Divide the patients up into STEMI versus the non-STEMI. Even if you don't have STEMI, if you start with a VF-VT shockable arrest, which is what most of these patients are in these two series, okay, chances are pretty good that it's a coronary, acute or chronic coronary disease causing your arrest and everything here. So again, we're kind of factoring that into the guidelines. Here's more pertinent to us. Here's 6 U.S. centers, 6 years, looking at 269 patients. Again, post-BTVF only, not PEAA systole. 2 of these hospitals cath everybody. 2 do what we do, which is kind of decide if we want to cath them or not. 2 of these never cath anybody until they determine if their patient's going to wake up neurologically in a few days and so. And again, what you can see here is that percentage of patients is pretty high, even if you don't have the STEM, for having coronary artery disease. And again, maybe early cath. Again, not randomized. Doctors are choosing who they're going to give the early cath to, but maybe you do a little better with a more aggressive protocol of resuscitation with cardiac cath. Okay? Now the bad news is, and I'm sure you guys deal with these outcomes as well, is the bad news is we have a lot of obstacles against us in Detroit. So here's a 2008 study that looked at 538 patients in Detroit who presented to Henry Ford, DMC, Sinai Grace EDs with a out-of-hospital cardiac arrest. This is only 12, 13 years ago. Out of 538, 1 survivor. Okay. So the conclusion of this author was, in Detroit, out-of-hospital is almost a uniformly fatal event and everything here. And again, it's not because of your skill, it's not because of our ER protocols and things. It's unfortunate. It's these pre-hospital factors. And again, that's looked at in this study. Here's Joe Miller from our ER department work comparing post-cardiac arrest outcomes at Henry Ford Hospital versus one of our former resident fellows, Mike Danino's experience at Beth Israel in Boston. And what you can see between the 2 patients is that we had this is patients who made it to the ED, so that's again why we're not dealing with 1 out of 500. But again, our survival is 13 versus 39% at Boston. And again, it's not a reflection of Henry Ford Hospital versus Beth Israel. It's a reflection of these pre-hospital factors. So only 15% of the patients that make it to the Henry Ford ED, frankly, start out with a documented BTVF, almost 50% asystole and everything here. Low rates of bystander CPR in the community. Lactate 13 versus 6, against our patients. And again, their predictable poor outcome before they even get to the ER door, 90% are expected not to make it here versus 2/3 and everything here. So again, we've got to, no matter what we do and everything in the hospital, we've got to frankly overcome these terrible pre-hospital things. And frankly, we have survivors. We had an April survivor and a CI patient who literally the family called EMS and they said, we can't get you a rig and everything here. Throw him in the car and get there. And he came to the car. He got resuscitated with still a shockable rhythm in the driveway outside Denver. He woke up and went home post-hypothermia there and everything here. But again, it's these pre-hospital things that are just very difficult to overcome. Everything here. Now, Gene and Jackie, pay attention. Certain guys we don't want. Certain guys we don't want you. We don't want you resuscitating some people. Okay, now who shouldn't be resuscitated? Here's 21,000 Denmark patients with cardiac arrest. I'm going to Denmark in September. My wife's got a meeting there. I'm kind of looking forward to that and everything here. But 21,000. Here's survival, 30 days or 1 year. Patients under 65, 65 to 75, and over 85. And what you can see is you don't have a cardiac arrest at 80, 85 years of age and walk out. Okay? Now, things are getting better. This is of the survivors who goes home with a good brain function. The young guys do pretty good. They're everything. So the majority actually go home neurologically intact. But the big take-home message from this is there's a lot of cardiac arrest patients who frankly have no chance. So if you didn't get shocked in the field and you arrived at the ER with ongoing arrest, which is not that infrequent, 3 out of 9,000 survivors did everything here. So again, they come to you guys with airways in already. They got the thumper going and everything here. It's kind of hard to stop at that point, but there's some real good data here that, again, if it's not a shockable rhythm out in the field and it's got that multiple minutes going on, frankly, we're probably not doing anything good resource or outcome-wise by even offering resuscitation or anything further on. Okay? So again, we got our 100 patients who rested. ER docs, EMS going to get back about 40. Everything we're going to talk about going forward now is what can we do from that 40 initially here and kind of get a higher rate of survival with a good neurological function and not lose as many patients there as we typically do. And again, what the guidelines want us to consider is 2 possible therapies that may be helpful. Is heart catheterization or cooling. And the cool buzzword now for cooling is where it's not therapeutic hypothermia, but it's temperature management is now recommended. And next time you recertify an ACLS, this will be the updated new content, is that every post-cardiac arrest should be considered for temperature management, and I'm going to explain what that means coming up. Okay, a couple important studies provide the basis for hypothermia. This is 2 studies in the New England Journal in 2002. This is a multi-center, 5-6 hospitals in Europe study by Dr. Bernard. 77 patients. Over 80% of patients screened for the study rejected. Okay, so it's a minority of ER patients that were considered only VTVF. ER doctors threw cooling bags, everything at these patients, externally cooled them within minutes of arrival in the hospital emergency department, down to 33 degrees or so. They cooled them for 12 hours versus a control group of that, and they evaluated them for survival to the hospital without a bad neurological injury. What you can see is, again, you got your 77 patients, you got your 33 degrees and everything here. They're using these extensive ice packs around the head, neck, torso, and the limbs. Sick people, you see multiple shocks, multiple doses of epi in these patients, so they're about as sick as you can get. All these cardiac arrest studies evaluate the patient on what's called the CPC score. So again, we want our patients to go home with normal or mild disability. These are generally regarded as adverse outcomes, so they're usually grouped together in most of these studies. And again, what this initial study, randomized study of hypothermia, shows that when you look at discharge with a good neurological function, it was higher in the patients with hypothermia. And here in the death rate, it was lower by about 15-20%. Absolute difference in favor of 12 hours of hypothermia in these 77 randomized patients. Okay? Same issue, New England Journal. This is about 250 patients. Similar design, cooling to 32, 34, 24 hours. Again, only focusing on VTVF. Same output. Less than 10% of the ER cardiac arrest patients included in this one here and everything here. And very similar outcomes. So here's that discharge with a good outcome. 16% absolute difference favoring the hypothermia. About 14% in overall mortality at 6 months favoring hypothermia. So 2 landmark, fairly good, robust studies, small numbers. 2002 established pretty much the standard of care for patients, at least with VTVF cardiac arrest going forward. And the resuscitation guidelines starting in 2003 become strong advocates for hypothermia, despite, again, some limited numbers and a very small defined VTVF cardiac arrest population. This then becomes incorporated into this is the 2010, get your patient back and return to spontaneous circulation and assess everybody. EKG changes or an active MI going on, and again, consider cooling in everybody. And again, the cooling basis is can you prevent that neurological injury and that everything here. And then again, officially in these 2010 guidelines, at least the cardiology guidelines, a level 1, everybody should get it after cardiac arrest from a VF or VT. 2B, meaning you can consider it, mixed evidence and everything for a cardiac arrest not due to VT, VF, or for instance for your inpatient arrests and things like that and everything here. So again, those 2 studies really drive the clinical evidence base and everything since 2003. Okay, you can cool patients 2 ways. Externally, I've read both of those 2 promising first studies use that rapid ER doctor ice packs and things here, or internally and everything here. And what we use at Henry Ford is the Zoll Alcius intravascular temperature management system. Used to be called Alcius. Zoll bought Alcius in 2009. And This is the Arctic Sun. We've had this at Henry Ford for probably 10, 15 years. We treated maybe 5, 10 patients in the early stages with this device. We found it's easy to apply. The nurses know how to use it. It didn't consistently get or keep the patients cold enough, frankly. So this uses a temperature sensor, either bladder or somewhere else on the patient here, and then these 3 pads that go upper legs, torso, and chest, feedback on itself and everything here. And again, this is used in some of the studies that have been done and everything here. This is the most commonly used external cooling device in the United States now. This is the device that was used in the pediatric cardiac arrest when it was just in New England Journal in May. This is the Cincinnati Sub-Zero Blanketrol. Same concept. You got this vest, you got this head thing that even gives you a fancy cooling of the scalp and the brain and everything here. And then you're going to circulate water through this closed system here to externally cool the patient. You can generally get them and control temperature very well between 30 and 40, again, using the water flow and things here. What we've used persistently since 2010 is the Zoll Alcius device. So again, this is a cooled saline bath in here that's connected to a closed catheter system. We put an intravascular catheter in the femoral veins. There's 3 of these cooling elements. And then again, just circulating venous blood across the surface area of this frigid intracatheter solution here is enough, frankly, to generate you effective and very, very well regulated control of the body temperature, literally within a 0.1 degree or so of exactly what you want. We've treated about 60 patients or so, and frankly, we've only had maybe 4 or 5 where we've had either mechanical problems or things where we couldn't accomplish what we wanted to temperature-wise with it. So we found it a very good system in terms of maintaining and achieving the temperatures and things that we want to do and everything here. Okay? Our protocol, again, focuses on the VT, the VF patients. Again, you got to get the patient back. They can't be waking up or starting to follow commands on their own. That's probably too good. And again, just like MI and stroke, probably earlier is better. So you want to try to cool within 240 minutes or 4 hours in most cases. Again, we have a collection of things here. And again, the protocol is written, and the implementation of the protocol for you guys, for us, these aren't rigid things and everything here. Frankly, we did hypothermia along with the ER between 2002 and so and 2000. We had no survivors for literally 5, 6 years because there was really no purposeful good patient selection going on to exclude patients with these and everything here. Again, when you do VT-VF alone, you want to get a survival. Hopefully you're in that 25 to 50% range, again, which is frankly, if you're falling way below that, you're probably picking patients who are hopeless and things here. So again, these are mainly criteria just to avoid futility more than that we think it's going to be a dramatic things here. So again, we tell our fellows and staff and rounders, again, none of these are absolute. We're certainly willing to consider it. ER, frankly, has been very responsible in terms of sharing responsibility and things like this. So again, we're not treating a whole lot of non-VT-VF patients and everything here. We launched the official intravascular cooling, I think, protocol in June 2010. Again, we target VT-VF or witnessed. Our program says if you're having a STEMI, we want to fix the STEMI first and everything here. We chose 33.5, and we'll talk about temperature in a few minutes. Want to get it going within 4 hours. And again, what we do is we cool to 33.5. We start the clock then. We measure 60 minutes we measure 24 hours from that point, and then we begin warming the patient there as the next phase of the treatment and everything for them. Who can get it? We want it to be collaborative between the ED and the senior staff so that they won't write bad notes like that about us and everything that we started. We prefer the internal. Again, we've had pretty good success with it. We started putting them all in the cath lab, but frankly, it's just a pretty simple venous insertion over a guide wire, so now we certainly are very comfortable with our fellows doing it unsupervised and everything here. Because primarily of nursing issues, and this is something Dr. Swiderick and I have been in too many meetings and discussions about and everything here. Because we're not doing a whole lot of them, it's a little difficult on nursing concepts and nursing familiarity and things here. So part of the protocol is if we're going to cool for cardiac arrest, then again, we want the patient sent to P5, and we want the primary team to be the CICU. It's a little more difficult to move these patients around. The cooling thing doesn't have a good battery and things and everything here, so you've actually kind of got to disconnect it. So again, we like the console to meet the patient up in P5 or where we're going to put it. If we've got no beds, then it's okay to start it down in the ED. There are 3 of those cooling systems in Henry Ford Hospital. Used to be 2 in the ER and 2 in neuro IC. We're down to 1 ER cardiology one that's kept in the ER. That's a newer, better machine that gets you cooler faster. There's 2 older machines in the neuro ICU. So basically what I'm saying is that cardiology's been freeloading off these other divisions, which is true. And what we do is you basically call the charge nurse and we say we got a patient here. We're not going to put it down in ED. We want the device then moved up to the ICU or the cath lab. It's a 9 French venous system and everything here. Again, we're putting it in. And then we'll talk about this, but most patients are ventilated and sedated. Interestingly enough, I don't know if, I know there's a little bit of paralytic literature recently in critical care about kind of mixed results and things here. The hypothermia subset of cardiac arrest is actually moving a little bit away from paralytic agents. And the reason for that is because even in our own experience, we're seeing some of these prolonged ICU myopathy kind of scenarios and things here. And patients are waking up neurologically with decent outcomes, but really troubled by muscle weakness and focal things here. So we are considering, but most places are starting to move away from actually paralytics in most patients here. So again, you're going to look at hypothermia as cardiac arrest, get them as quickly as you can down to the 33.5, keep them there for the 12 to 24, then warm slowly, and I'm going to go over our warming. We warm at 0.2 degrees per hour. And then again, this period, this is where you get the secondary sepsis and everything here. Here is where most people say we want to prevent fever. So we actually leave the device now in out to 48 or even 72 hours in most patients. Balancing problem here is once the body warms up, that's a pretty prothrombotic, good-sized catheter in a vein that's sitting there. Okay, so again, we want to balance that, but maybe preventing fever is pretty good. Now, shivering is going to resist you getting down to 33.5 and starting that. Has some bad adverse physiological effects. The bigger your arrest is, so the more brain injury, the older the patient is, they don't fight you too much on temperature. So the body really wants a shiver in that 36, 37 degree range and everything here. So what we've done for the last several years is, again, we only paralyze when we're getting to 33.5. Then we like to withdraw it and not do the whole 24 hours paralyzed in there. We found that actually works pretty good and everything here. Because again, once you've achieved that 33.5, the body kind of gets a little homeostasis. And then again, what the other guidelines are starting to show is maybe you avoid the whole damn paralytic to start with, and you can use either your standard sedation, good doses of IV magnesium, or cool the core, warm the surface is actually becoming kind of the in vogue way to do it. So put a warming blanket externally, but cool internally may actually be less drug and things that you want to do and everything here. So again, a trend towards less paralytic use, particularly avoid the long paralytic infusion for the whole period of cooling is kind of what we're looking at that. You got to be a little careful with potassium shifts. You shut down metabolism so they all get hyperglycemic. You generally do not need to anticoagulate for balloon pumps or these other things because the cooling actually really shuts down the coagulant system really good. Brady, we've probably had 3-4 pacemakers out of our 60 patients. So again, Brady is more at 30, 31, 32, and things like that. And again, we don't try feeding during any of the cooling. The gut is kind of shut down and not working anything and everything here. When we finish our 24, then we're warming patients. We're going to warm them slowly, 0.2, so that's about a 10 to 18 hour per process to get them back to 36. Watch for hyperkalemia and everything here. We'll leave it in, again, up to 72 hours to prevent fever. And again, one thing is you can't pronounce patients dead when they're cold. So again, you're communicating to families and things like this that it's going to be several days. You can't withdraw care in 24, 48 or assess neurological function in a hypothermia patient at 24, 48 hours the way most of us used to do it in terms of standard of care or in terms of our practice and everything here. Now, frankly, that whole period you're doing this, you've got to invest some time in family communication. And this is this is a pretty telling data in terms of family communication. Again, I've been in that room downstairs with the ER doctors, and they've told the patients, we got him back, and Grandma's got a chance and everything here. I'd rather you say it's 10% chance she's probably not going to make it. That way, Dr. Hudson and his team look better when they wake up on day 4 or day 5. But this is a UCSF study, 2009. Interesting, 40% white, about 20 Asian, 20 black, 20 Hispanic. Okay, these are real family decision makers going through an ICU, and they did this structured interview and everything, and they sat down with them. They told these 50 families, your loved one will not survive this hospitalization. Again, this isn't just cardiac arrest. This is more your general ICU sepsis and everything here. Your loved one has absolutely no chance to survive this hospital stay. Okay? Even with that blunt prognosis for the patients, 64% of families, again, are going to be unwilling to hear that or do it. 40% said, you as a doctor, I hear you, but you can't predict that with certainty or anything here. 36 want divine intervention, okay, and 24%, you're telling me that, doctor, but I need to see it myself. Okay, that's 0% survival. Same study then, they told the patients, all right, you're in ICU, you got a bad outcome, your chance of your loved one surviving is 0, less than 1, 5, 10, 20, 50, 80, or 100% chance of surviving. But your loved one can only survive with at least 2 more weeks of ICU therapy, including a PEG and a trach. Okay? With 0% chance of survival, still a fifth of patients' families say, keep doing it. With less than 1% chance of survival, 32% of families still want you to go on. It's everything here. So again, we worry about, are we getting it right, 10% chance or 50% chance? A lot of patients' families are uncomfortable withdrawing or anything early on. And again, that's kind of been our experience. So you got to do a lot of family manipulating and communicating in this period. And frankly, that's what the hypothermia lets you do. Here's our data up until May of this year. So we started in June of 2010. We're treating roughly 1 patient a month consistently over that 10-year period. We have a 42% survival. Most of them are neurologic intact. We've really struggled with the downtown ED patients, frankly, and most of our survivors are West Bloomfield, Canada. Most of our survivors are STEMI patients, frankly. We've had 7 cases where we said, we don't think they're going to do it. We're not going to offer it at least. And again, what we did, what we kind of said that we do, is that we withdraw quick in those patients. So whether it would have helped or not, we don't probably know. 1 patient did survive and might have benefited with a poor neurologic function. Okay? So again, that would be the end of the talk in 2004, 2010. But the field has changed. And in fact, the field has changed so that the newer studies really are starting to cast doubt on whether the hypothermia itself adds to modern day ICU therapies and support. So here's 1,359 patients. If cooling is good, cooling sooner should be more advantageous to get the patients and protect the brain. So here's half patients randomized to 4-degree saline infusion, 2 liters by the EMS system in the field before they get to the hospital. And then they arrive at the hospital, resuscitation goes on. About 70% of patients end up getting therapeutic hypothermia. And what you can see here is both in the VFib population and the PEA systole, no benefit of cooling the patients with cold saline out in the field, even though you did arrive at the ER with about a degree less temperature and did achieve your cooling at a slightly higher rate. Okay? And then the more pertinent study is what the targeted temperature management study, or what goes by the TTM study. Both these studies presented at the same American College of Cardiology meeting in 2013. And again, what you see here is now instead of 77 and 250 patients, much larger study, so 939 patients, half going to get randomized, either external or internal cooling down to 33, The other half, or what's called the control group, going to have cooling measures, or what we call temperature management, to just prevent fever and target 36 degrees. Okay? Much more robust, much more better done study, frankly. You've got 77% VFET. You've got a lot of CPR, SARS-TEMI. The only thing that wasn't done well was the cooling. So instead of the ER doctors pouncing on these people with ice bags and things, starting cooling within 5-10 minutes, the way they did in those 2 New England Journal studies, by the time you actually randomized, enrolled, screened these patients, you were 2 hours before you started, and you were almost 7.5 hours post-arrest until you achieved the 33.5 and 36. So this study is rightfully criticized in that maybe it didn't give the cooling the effective chance and everything to be implemented and everything active. The biggest difference, though, compared to the other studies, though, again, is again, here's the old studies. You got your cold group versus your normal group. Now you got your normal group tightly regulated at 36, okay, to prevent fever in this study, okay? And when they looked at the comparison in the 900 patients, 33 versus 36, there was not even a signal of any benefit at 33 degrees of cooling. So absolutely identical. The point estimate actually favors the 36-degree group here in terms of this is long-term survival. I think it was 260 days to the end of the study here, but no early benefit, no late benefit, overall survival, survival with good neurologic function, everything here, virtually identical in the two groups. Okay? So if you're the Zoll salesperson selling the intravascular temperature management system, you no longer have a hypothermia device, you've got a temperature management device, right? And in fact, that's what is taking place now, is all the gurus and the supporters of hypothermia, as I said, the ACLS guidelines are going to give you the option now to do either 33 or 36, but do something like they did in this study. And again, here you see the comparison of the two older studies. This is the IV cold saline. The big difference is they just didn't cool effectively. So you got a much bigger, better, robust study, well-defined neurological assessments and outcomes and things here, but maybe not quite fair enough for the 33.5. Okay? Here's kids. So here's New England Journal from May. Kids have more respiratory than cardiac arrest. Most community hospitals don't have ICU for kids, so they frankly got to be flown or helicoptered to tertiary care centers. But again, here you see 300 kids randomized to 36 or 33. They all got that Cincinnati Blanketrol circulating external thing on him here. And again, what this study shows, the average age in this is about 2, I believe. So it's a lot of neonates and a small number of adolescents and things here. But absolutely no benefit in terms of death with good neurological outcome or anything here. So the last two major randomized studies have been very negative in terms of the hypothermia principle. Here's a French study just from the last few months. What's better, cooling internally or cooling externally? So this is ice packs in that in the red versus the device that we use. So the CoolGuard Celsius catheter and everything that you can see here. Here's temperature achievement. So like I said, the intravascular is pretty quick. So within the first hour or so here, you're getting down. You got a little more exquisite control for the patients here. Overall outcomes at 30 days, really no difference comparing internal versus external. The point estimate favors the internal cooling being a little bit better. The biggest difference in this study, frankly, that was statistically significant, is the workload or labor you ask the ICU nurse to do to regulate temperature is actually substantially less with the cooling catheters. And frankly, that's been our experience. The nurses, frankly, like to paralyze the hell out of them and let them sit there and do it and everything here. But they're actually pretty easy to care for there. Whereas the external, you got to take packs off, take pads on, all that kind of thing. So from a nursing workload, frankly, maybe the internal has some good advantages and everything here. Hypothermia is good. The combination then of hypothermia with cath and revascularization becomes it. This is Finland, the initial medical center that started publishing on hypothermia and everything here. They went to a protocol in the early 2000s where everybody got hypothermia and cath. And again, what you can see is before the protocol versus after. The combination of both maybe slightly more effective than either one apart and everything here. Here's Seattle, Washington with a very good tertiary care ambulance EMS system. Again, you've got a survival here not of 10%, but almost 17%. And in Seattle, over 2001 2009, about a quarter of the patients get hypothermia, about a third get an early PCI. But there's actually bigger differences between the PCI and the no PCI group versus the hypothermia no. And who does the best? Well, again, not randomized, but you do best if you get both. If you get therapeutic hypothermia and a PCI, you end up with the best outcomes in Seattle. And again, this is that in-car registry. Again, same thing. 6 hospitals, big centers that have big interest in hypothermia. Here, everybody's getting cooled. So again, they're true believers in cooling and everything here. But when you look at the non-STEMI patients here, again, cath versus no cath, doctors are selecting. You want to be careful with this data. Are selecting who they think is going to survive. They're small numbers, but if you make it through the hypothermia period and you start to wake up and you've got neurological function and you get your cath a little bit later, you probably do okay as well. But again, that's very biased by survivor effect and patient selection. So these are the current guidelines by the European and the U.S. for interventional cardiology interventions and things here. Again, both European and U.S. guidelines say hypothermia for everybody after VT/VF arrest. If ST elevation is there, go to the cath lab right away and treat an MI. European guideline says if you don't have ST elevation, but you've got a high suspicion of ongoing infarction, then level 2, probably recommended, probably okay to do a cath. And the U.S. guidelines don't give a specific recommendation to it, but they say it's reasonable without ST elevation. If you think you're dealing with an ischemic patient or an ischemic etiology of the cardiac arrest, which again is going to mostly be VT/VF, right? Then again, it's reasonable to do the cath early on in the course of the resuscitation. Okay. Now the problem with doing caths in these patients is that if you do caths in these patients here, you end up destroying your hospital performance measures and everything here. So in fact, the 3 states in the United States that have the lowest rate of early cath intervention for cardiac arrest and for cardiogenic shock are Pennsylvania, Massachusetts, and New York. Why? Because they have public reporting of their PCI outcomes. So for instance, that is where Dr. Danino is now. They ended up on the front page of the Boston Globe for a horrendous survival with their PCI program because they were doing 20, 50 cardiac arrest PCIs a year where your chance of surviving at best is 50%. So if you end up doing 20 or 50 cardiac arrest patients a year of PCI where only half are going to make it, again, that's 20, 50-fold chance of dying compared to even an acute MI PCI. You end up looking like a poor performer and outlier. So the interventional cardiology community says, we're not going in automatically and fixing all these patients here unless you need to take these outcomes out, okay, and not include them against the hospital performance. And this is an interventional guideline that was just published 2 months ago. You know, they come right out and say it. We kind of want to get the interventional cardiologists out of these patients and everything here. We want to choose who it may be futile, and they don't give a specific criteria or anything here about how you resist it or who doesn't need cardiac arrest. But frankly, he said you ought to look at these unfavorable resuscitation features. So if it's unwitnessed, if it's non-VT/VF, no bystanders, pH less than 7.2. I mean, you guys, and we have a lot of survivors that have pH as well under 7.2. A lactate of 7, that's high, but again, there's mixed data on that. But if you got enough of these unfavorable ones, maybe ER doctor, cardiologist, maybe everybody ought to step back and not offer cath and hypothermia for these patients and everything here. But again, unfortunately, no good formula that in that earlier resuscitation, that first few hours, lets you pick and choose who's the best one to cath and do this here and everything here. But it is a hot topic. Okay? Now, in terms of here at Henry Ford, what are we going to do here? How are we going to split this wonderful group of patients up here and everything here? And this is content of a document that I gave Dr. Swiderick an offer that she couldn't refuse here and everything here. But to balance who needs cardiac procedures, who's got a more likely primary cardiac etiology, nursing concerns, because again, the infrequency that we do this really makes it difficult to train all the ICU nurses across the hospital and everything to do it. We've kind of come to peace with, again, we're recommending with primarily the VFVT, but again, even the exclusion criteria that are in the written protocol, again, they're all relative. We've been very happy that people have chosen who to consider for this and everything, relatively responsible. If it's VTVF, again, they should come to the P5 with the CI as the primary service. We're going to generally offer them therapeutic hypothermia. Within our group, we're frankly, during the daytime, we're more willing to cath people even without ST elevation. Can we get everybody in 24/7, like that Filipino guy at 1 a.m. on a Sunday morning? We're not 100% there and everything here, but we're working towards that and everything here. The bigger group of patients, these PEA asystole, again, we're willing to consider it in certain people with less negative prognosis and things here. And so what you can see in that, or if you guys get called first for that and you think maybe they're a good hypothermia candidate, or they're more salvageable, or it's a great functional status before they went down, again, those are the things we kind of factor into everything here. We're happy to kind of come see them in the ED. If we make a decision on the non-VTVF, the non-ST elevation, yeah, we want to give them a chance with the hypothermia. Again, we'll see that, make that decision with the ER staff. That patient should go to P5 and should get the CICU as their primary service. And in exchange for that wonderful agreement, then Dr. Twitter guy agreed that she's gonna allow us to not have those patients long-term on cardiology so much. So after the first week, when their decision-making is done in terms of revascularization, ICDs, and things here, we're going to ask you guys to take most of those patients for the longer-term issues of the PEGs and the trachs and the inoxys. We're still ongoing support at that period of time and everything here. So again, this comes up. I get called once a month by an ER doctor here saying, "What do you do?" and everything here. The answer is, put a consult in there down there. We'll come down and see them. And again, between ER docs and either interventional cards or consult and decide if we want to offer them cath or therapeutic hypothermia in both cases and everything here. These guys, again, are more straightforward for us and everything here. Again, as you think about the whole issue, all this data and all these studies, again, they're really focusing on people with cardiac arrest thought to be a primary cardiac or arrhythmic outcome. So again, overdoses, PE, thoracic dissection. None of those people should be considered for, yes, they had a cardiac arrest, but none of those patients should be considered for hypothermia and things here. We have no good data. And again, they have to have their etiology of their arrest determined in that process, treated and everything here going forward. So again, I'll finish with this. It's a terrible, terrible group of outcomes, but frankly, I would raise my hand just like you guys all did at the if for nothing else, it gives us something that may be useful in patients here. It gives us something during that first couple days to discuss with the family and give them every reassurance that we've tried and been aggressive in terms of resuscitation and care. As long as we choose our patients carefully and things like that, where it's not an undue use of resources and things like that, I think we go forward with it. West Bloomfield has this in place already. They've chosen, frankly, to do pretty much identical to what we do, but they're using 36, frankly. So they're going to put the device in, but they're going to cool at 36 and everything here. We're going to stay 33.5 for the time being here and everything here, using the process here. And again, we'll triage as I showed you on the slide before. Okay, so any questions, issues, any unit things? Yeah. You avoided all the ER snide remarks and everything.
Is there any data to support cooling beyond that 4-hour period?
You mean started later?
Yeah, starting later.
The reality is that everybody's struggling to get it done within that period of time. I didn't show it. There is one study, 100 patients or so. Frankly, 32 is better than 34. There is data at centers that do a lot more than we do it, that as you get better at it, you do it a little bit better with more rapid time or achievement of the cooling. You missed the one slide, though, that the two studies, frankly, though, that have done in the field IV frozen saline, actually both have been neutral to negative. So real rapid getting down is not looks like it makes a difference or added. So again, whether the whole cold principle works, to emphasize earlier is better, no, I don't think there's good data.
Is there data on is longer better, 12 versus 24 hours?
Nobody's gone beyond 24. Frankly, we've always worried whether 12 is equal to 24 from a resource point of view and everything that their needs of the patients usually are not that great. We have had scenarios, frankly, if family shows up at hour number 8 and says, we never wanted this, or if you find out the functional status was horrendous, literally, and the patient hasn't gone out of the home except for the doctor's office in the last 5 years, you get a brain bleed back on a CT scan because you are able to do some limited neurologic exam. We'll shorten it so we'll warm them up 36 faster so we can pronounce them sooner there and everything here. But I would say you'd be at least 12 is what every study would show. And beyond 12, and 24 out to 48, no, not a lot of benefit there.
Mike? So we currently don't do this for in-hospital arrests.
We've done a handful.
Okay, so when my fellows get a phone call from, a scared resident on the GPU from a blue alert, what's sort of the guidance in terms of, giving them advice on therapeutic temperature management?
So I would say the majority of those, frankly, don't have a cause usually, right?
Right.
I mean, there's a handful a year that have an ST elevation,
Correct.
MI or something easily, where everybody would agree they're cardiac and things here. Same situation. I mean, it's going to come down to EKG. Can you make it? Do they have a known history of cardiac disease? Do they have a cardiomyopathy that gives you more likelihood that it was primary rhythm and things to do it? Majority of those, frankly, even the ones that happen on H5, I5, they've been unstable for I mean, you can go back and you usually find vital signs that are abnormal and things and that going on. So we would consider them. So I guess the guideline would be if you don't have your initial survey doesn't show anything else and you think, again, the guidelines of who you ought to is if you think acute ischemia is part of the presentation or etiology, then we've got to decide together about where to take them. Realistically, though, given P5 census, and you got to get the patient off the floor. I mean, they can't stay on the floor and everything. Here, they're going to probably go to you guys first, and then we sort it out in the next hours.
Yeah, and I think, again, it's important for all the fellows to have in the back of their mind that this is, again, for patients that we primarily think has had a cardiac etiology for their cardiac arrest. This is not, like Mike mentioned, the PE patient that arrests, or the GI bleeder that arrests, or anything like that. This is primarily someone that we think had a cardiac event causing the arrhythmia that we're seeing. That's going to be very important because, again, I've seen a lot of people in blue alert situations. That's the first thing that comes to their mind is, should we cool this patient? And so helping them walk through what the underlying process is really important in this scenario.
The other limiting factor in inpatient is inpatient that you're talking 10-15% for a community when inpatient traditionally has been higher. So you expect 40-50%, frankly, to make it an inpatient. So the other thing is that usually because they're resuscitated a little bit better, we hope that they may not be as neurologically, but frankly that's hard to predict in that initial hour when you're making the decision afterwards, and nobody's that good at that, frankly.
You talked about your inclusion criteria, BTVF, for witness arrest. So what does a witness arrest mean to you? We don't know the rhythm?
So I can't give you a black and white, but I give you 15 years of doing it. The one that we don't like is I saw grandma at 10:30 and I walked in at 11 and she's down. I mean that's pretty common. That's not witnessed, and that scares the bejesus out of us that it's a pretty prolonged period of hypoperfusion, even if we're able to get them back. So again, the in-hospital, those are usually, but you get a mixture there too. I mean, frankly, the nurse goes through on vital sign check and you don't have it is not witnessed, whereas fell to the floor, getting off the toilet with something that's witnessed and everything. So again, it's not to evade your question, but it means literally being able to tell the time of onset here, and high likelihood that there wasn't several minutes of that before any resuscitation or recognition took place.
So you're taking for granted that those are probably BTVF, something like that.
You're taking for granted a better proportion are, but no, I wouldn't say.
In terms of post,
Just finishing that one thought. If a shock's given in the field though, with an AED and without, that's pretty good.
Right.
I'm a lot more interested in that patient there, frankly, and everything.
after return of circulation, is there any algorithm how to manage the arrhythmia if it comes back, or if there continue to be tachycardic, otherwise when it's white complex or bradycardic, is there any way to continue amiodarone drip or?
No, I mean you've got your ACLs, which is going to favor only amiodarone, right? In most cases, and things here, hyperkalemia and things here. You've got your atropine and your combination of transcutaneous or transvenous pacing in the portions in here. The majority of people we've had to put transvenous pacers for Brady, frankly, started out either Brady or borderline Brady, so that we put the pacer in right at the beginning of it and didn't see it markedly worse. The reported one, or the biggest physician concern usually, is that the hypothermia will worsen Brady in some people. Again, it hasn't been experienced. It's a big pertinent thing at 33.5 because it's probably a little bit lower than things here. But no, nothing you want to avoid or do it. In general, the arrhythmic management, though, is frankly, you want to fix the problem. So you want to get to the cath lab and fix the unstable and limit the duration and the use of the amiodarone, particularly if you're dealing with a recurrent arrhythmia, or if you've got a second VTVF, or frankly, if you guys had an unknown primary cause of arrest, but you're seeing a lot of PVCs, and then you get a clear VTVF, and then afterwards, maybe then you reconsider it and say maybe the first one was more likely cardiac. Although frankly, most of those have pressors in there, and an albuterol treatment, and what the cause is, and unfortunately, it's not till their opponent comes back of 100 that you say, yeah. Hardstell took me on this one. Hear that, everything. So they're challenging, but like I said, we've been happy with that and everything here. Do you know? Oh, Jen left. I was going to say the one patient we haven't really figured out where the best place for them is the environmental hypothermia. So the fortunately it's a small number, but it's a few patients a year that come in. The cooling device, the cooling slope flash warming device actually works very, very well for those patients and things here. But yet we've struggled to frankly to get the nursing competencies and things out of P5 to use it and everything here. So again, my initial response would be, we'll give you a P5 bed and you guys can be the primary up there with our nurses and that and everything here. If the number ever gets too big, then frankly we'll, because of our bed urgency, we'd have to push back on you to get one of your pods up and going, but and everything. But those are few and far between. Thank you.